All right, let's dive straight in. Today, we are tackling one of the biggest, most time-critical emergencies in all of trauma and orthopedics, acute compartment syndrome. We're going to cover exactly what you need to know when a limb is on the line, how to be fast, how to be decisive, and how to be right.
And this quote right here, it just says it all, doesn't it? The stakes could not be any higher. This isn't just about saving a limb from amputation. It's about preserving its function, its future. And for any surgeon, especially in a high-pressure exam, understanding that difference is absolutely everything. So here's our game plan. First, we're going to get into the why, that vicious cycle that drives this whole process. Then we'll talk about spotting the emergency, and of course, the surgical fix. We'll also cover what happens after the operation, and we'll wrap it all up with the key points you need to absolutely nail your viva.
Okay, first up, the vicious cycle. Look, to stop this freight train, you have to understand what got it moving in the first place. This pathophysiology, it's the foundation for every single decision you're going to make from here on out.
So what are we really talking about? Here's the textbook definition you need to know. It's all about pressure building up in a space that can't expand. Just picture your muscles all tightly wrapped in the sleeve called fascia. That's your closed compartment. When an injury causes swelling or bleeding inside, the pressure skyrockets, and it starts to squeeze the tiny blood vessels shut. That cuts off oxygen, you get ischemia, and that's where the tissue starts to die. And this is how it spirals out of control. An injury causes swelling inside that rigid fascial box. That rising pressure chokes off the blood flow, which causes the tissue to become ischemic. But here's the nasty part. That dying tissue then leaks even more fluid, which cranks the pressure up even higher. See? It's a horrible feedback loop that just keeps getting worse on its own. And the only thing that can break it is a scalpel. So how do you actually spot this thing in a patient? This is so important. Compartment syndrome is a clinical diagnosis. Your hands, your eyes, your judgment. That's what makes the call, not some fancy monitor.
Now, this is a classic exam pitfall. You've probably all learned the 5 Ps, right? Well, look at them. Pallor, pulselessness, paralysis. By the time you see these things, you're too late. The damage is done and it's probably irreversible. The real key, the sign you absolutely cannot miss, is on the right. It's pain that is way out of proportion to what you'd expect from the injury. And, critically, excruciating pain when you gently and passively stretch the muscles in that compartment. That is your 5-alarm fire.
And let this sink in, because this is probably the single most important clinical point. The pressure in the main arteries is much higher than the pressure in the tiny capillaries that feed the muscles and nerves. So a patient can have a booming, easily palpable pulse in their foot and still have a dying limb. If you say this in a viva, it shows you really truly get it.
So, is there ever a role for measuring pressures? Yes, but it's for specific situations. Think about the patient who is unconscious or intubated and can't tell you they're in agony. The number you need to remember is this delta pressure. It's pretty simple. You take the patient's diastolic blood pressure and subtract the compartment pressure you measured. If that difference, that delta, is 30 millimeters of mercury or less, that limb is in serious trouble.
These are your big red flags. Anytime you see one of these injuries, especially a nasty tibial fracture, your brain should automatically be screaming compartment syndrome. These are the classic scenarios that examiners love to use to see if you're thinking ahead of the game.
Okay, the diagnosis is made. The call has gone out. Now it's time to act. This section is all about the definitive solution, the fasciotomy. You need to know the anatomy and the steps stone cold.
The lower leg is where you'll see this most often, and it's split into 4 distinct compartments. You've got the anterior and lateral on one side, and the superficial and deep posterior on the other. The principle here is simple. It is all or nothing. Releasing 3 out of the 4 compartments is a failed operation. You have to release every single one of them.
And here is a huge surgical pearl. The deep posterior compartment. This is the one everybody misses. And if you fail to release it, the patient can develop what's called a Volkmann's contracture of the foot. It's this permanent, claw-like deformity of the toes and ankle with numbness on the sole. It is devastating and it is totally preventable.
So, this is your surgical roadmap. The gold standard is a double incision technique. You make a long lateral incision to get the anterior and lateral compartments. Then you make a second medial incision to get the superficial and, most importantly, the deep posterior compartment. And the final step is crucial. You leave the wounds wide open. We'll get to why in just a sec.
These images show you the textbook placement for those cuts. The anterolateral one runs just in front of the fibula. That gives you access to the anterior and lateral compartments. The posteromedial incision is made just behind the tibia for the two posterior compartments. You should be able to draw these from memory.
Now, just for a moment, let's look at the hand. It's a whole different ballgame. Instead of 4 big compartments, you've got 10 tiny, tightly packed ones. The thenar and hypothenar eminences, plus all the interosseous muscles. A single cut just won't do it. You need multiple, carefully placed incisions to make sure every single one is released. It's a great example of how the same principle, decompression, requires a completely different surgical strategy.
Getting through the surgery is a huge step, but you're not done yet. A truly complete answer includes managing the patient after the operation, and the problems you face here can affect the entire body.
See, when you finally decompress that limb, all the contents of those dead and dying muscle cells get dumped into the bloodstream. This is called rhabdomyolysis. It releases proteins that are toxic to the kidneys and potassium that can cause life-threatening heart arrhythmias. That's why post-op care is all about flooding the patient with IV fluids to protect the kidneys and keeping a very close eye on their blood work and ECG.
And what about those big open wounds? Well, there's one golden rule. You never close them right away. If you did, you'd just be recreating the exact pressure cooker you worked so hard to fix. The wounds must be left open. You'll go back to the OR a few days later, once the swelling has gone down, to wash them out and plan for definitive closure, which most of the time means a skin graft.
All right, let's bring this all home. This is your rapid-fire summary. These are the high-yield, absolutely essential points you need to have locked and loaded to deliver a sharp consultant-level answer.
These are the phrases that show an examiner you get it. The key early sign is pain out of proportion, especially on passive stretch. Surgically, your #1 priority is to never ever miss the deep posterior compartment, and you use a double incision technique to get there. Because if you miss it, you risk a Volkmann's contracture. Weaving these terms into your answer shows you really understand the core concepts.
And finally, always ground your answers in evidence. You don't need to quote specific papers, but saying something like, "My management would be guided by the principles laid out in the AO surgical reference and current DMS guidelines," just shows your practice is modern, safe, and based on solid evidence. So I'll leave you with this question to think about. You're in the OR, the incisions are made. How do you know if you've done enough? Well, you have to look at the muscle. Does it look healthy and pink? Does it bleed? Does it twitch when you touch it with diathermy? The compartments should feel soft, and if you're in any doubt, you can even measure the pressures again, right there on the table. It's about being thorough and not stopping until the job is well and truly done. Master these points, and you'll be ready.